Welcome to today's deep dive. We're really glad you're joining us for this one.
Yeah, thanks for being here. We have a pretty fascinating topic today.
We really do. We're looking at a brand new World Health Organization news release. This just came out on February 27th, 2026, and the headline here is just massive.
It is. It's a huge structural achievement in public health.
So the core of it is that Denmark has officially become the very first country in the European Union to eliminate the mother-to-child transmission of both HIV and syphilis.
First in the EU, which, is a really specific milestone.
Exactly. And for anyone listening who's interested in health policy or epidemiology or just, how good systems are built, that's our mission today. We aren't just going to celebrate the win. We want to unpack exactly how Denmark pulled this off.
Because it's not an accident.
Right. We're looking at what elimination actually means in the medical world and what this achievement means for the future of global maternal and infant health.
Yeah, and setting that tone right away is important. This isn't just a sudden stroke of luck. It's not a new drug that suddenly hit the market.
Right. It's not a silver bullet.
Exactly. It's a masterclass in health policy and systems design that spans literally decades. It's about what a rigorously maintained system can produce over time.
So let's start with the basics, because I think people hear the word elimination and they think the disease is just gone, like dinosaurs.
Right, yeah. Like it's been wiped off the face of the earth.
But that's eradication, right? Not elimination.
Correct. Eradication is what we did with smallpox.
Yeah.
Elimination, specifically EMTCT.
Which stands for the elimination of mother-to-child transmission.
Right. EMTCT is a very strict mathematical threshold set by the WHO. It doesn't mean the pathogens aren't circulating in the background population.
They're definitely still there.
They are. But elimination means you've driven the localized transmission down so incredibly low that it ceases to be a public health burden. It's an ongoing operational standard.
It's a benchmark you have to maintain. It's not just a historical endpoint where you plant a flag and go home.
Exactly. And the WHO, they don't just hand out this validation based on a single good year or a general downward trend.
The criteria are actually punishingly exact.
They really are. To hit the benchmark on the preventative side, a country has to prove they are routinely testing and treating at least 95 out of every 100 pregnant women.
95%.
Yeah, and think about what that requires. Capturing 95% of any demographic for a specific medical intervention that takes an incredibly tight domestic health net.
Because you're always going to have people who miss appointments or move or just fall through the cracks.
Right. So 95% is a massive logistical hurdle.
And that's just the front half of the metric, right? The back half is just as demanding.
Yep. Because you can test comprehensively, but you also have to prove the outcome.
The actual results.
Right. The new infant infections have to be kept strictly below 50 per 100,000 live births.
And according to the WHO release, Denmark didn't just hit this once. They had to sustain these specific numbers continuously from 2021 through 2024.
4 straight years. Which means the system is immune to standard bureaucratic fatigue.
Or funding fluctuations. It's just baked in.
Exactly. And the validation process for that data is intense. It's not just taking Denmark's word for it.
Right, there's a whole auditing process.
A 2-tier auditing process, actually. First, the National Statistics went through the WHO's Regional Validation Committee in June of 2025.
Okay, so the regional experts verify the methodology and the outcomes first.
Right. And once they cleared it, the assessment was escalated to the Global Validation Advisory Committee in August of 2025.
So it's a dual-layered independent verification.
Exactly. To make absolutely sure the data holds up under international scrutiny.
Which brings us to the big question. How did they actually do it? Because looking at the quotes in the source material from Dr. Tedros Adhanom Ghebreyesus,
The WHO Director General.
right, and Dr. Hans Kluge, the regional director for Europe, they really point to the domestic primary care infrastructure.
Yeah, Dr. Tedros specifically highlights the strong political commitment and consistent investment in integrated maternal and child health services.
The key word there being integrated.
Absolutely. That is the secret sauce here. HIV and syphilis screening aren't treated as specialized standalone procedures.
You don't have to go to a special clinic.
No. They are woven directly into the default antenatal care process.
So when you go in for your regular pregnancy checkup, it's just part of the blood work.
Exactly. And that default integration is the structural secret to hitting that 95% screening threshold. If a patient has to, opt in or travel somewhere else or specifically request the test,
The capture rate drops.
it inevitably drops.
Yeah.
Every extra step is friction. By making it an invisible, routine part of pregnancy care, the system removes the cognitive and logistical burden entirely from the patient.
And the financial burden, too. Sophie Lode, who is Denmark's Minister for the Interior and Health, she grounded this whole success in Denmark's universal health system.
Equal access for all.
Right. Which fundamentally alters the epidemiological landscape. If any portion of your population is avoiding screening because of cost or lack of insurance or fear of medical debt,
then that 95% threshold becomes mathematically impossible.
you just can't get there. Universal healthcare removes the financial friction that creates blind spots in national disease tracking.
And beyond the financial aspect, the WHO release really emphasizes the necessity of exemplary data systems and robust laboratory capacity.
Because the test is only as good as the turnaround time.
Exactly. A clinical intervention is only effective if the diagnostic turnaround is fast. If a routine screening identifies a positive case of syphilis or HIV, the lab has to process that result rapidly.
And the data system has to flag that patient for immediate therapeutic intervention.
Right. The speed of that data loop dictates whether the transmission to the infant is actually prevented.
And there's another pillar the WHO cites here, which I think is really crucial for you to understand as a listener. It's Denmark's high standard of human rights and respect for women's rights in healthcare.
This is foundational. Behind all these data points and percentages is a structural reality. A pregnant woman can walk into a clinic and receive screening without facing systemic stigma.
Or a paywall.
Exactly. That rights-based approach physically drives the infection numbers down. In infectious disease management, trust is a measurable variable.
That's a great way to put it. Because if marginalized populations fear punitive action or judgment, they just won't go to the doctor.
They'll circumvent the system entirely. Denmark's model proves that respecting patient autonomy is actually highly effective epidemiology.
Let's look at the raw data, because the WHO editor's note provides some incredible context here. It shows that these pathogens are still very much present in Denmark.
Which makes the zero transmission rate for infants even more striking when you think about it.
Let's take HIV first. The source notes there are currently about 5,950 people living with HIV in Denmark. So the virus is actively circulating.
It's there, but less than 0.1% of pregnant women are affected by it.
Right. And among that tiny fraction of a percent, the mother-to-child transmission rate has been driven down to absolute mathematical zero.
Driving transmission to zero while the virus remains in the broader population is an incredible stress test of a healthcare infrastructure.
It means the clinical interventions are executing flawlessly.
Flawlessly. When a pregnant woman living with HIV is identified through that 95% screening net, they administer antiretroviral therapy that suppresses her viral load to the point where the virus literally cannot be passed to the fetus.
They build an impenetrable clinical wall between the circulating domestic virus and the next generation.
It's remarkable, and the 2024 data on syphilis reveals these systemic mechanics from a slightly different angle.
Yeah, the syphilis breakdown is fascinating. The WHO reports 626 total cases of syphilis in Denmark for the year 2024. But the demographic split is what really tells the story.
Tell them the numbers.
Out of those 626 cases, 524 were in men, and only 102 were in women.
So that's over a 5-to-1 ratio.
Exactly.
And that ratio demonstrates the operational difference in how men and women interact with the healthcare system. Because women of childbearing age are routinely funneled into these maternal health protocols, they receive highly targeted, comprehensive care.
The continuous screening acts as a constant clearing mechanism.
It severely limits the disease's ability to gain a foothold among women. The preventative net is so deeply embedded in maternal care that the vast majority of the national syphilis burden is isolated to the male demographic.
Because men lack that specific, routine medical touchpoint. They don't have a mandated, system-wide equivalent of prenatal care.
Exactly. Now, the public health objective doesn't stop with HIV and syphilis.
No, it doesn't. The WHO news release frames this achievement as a stepping stone toward a broader goal known as triple elimination.
Right. Denmark has secured validation for 2 of the 3 targets.
And the final piece of the EMTCT framework is hepatitis B.
Which introduces a completely different demographic challenge.
It does. The overall prevalence of chronic hepatitis B in Denmark is exceptionally low. It's estimated at around 0.2 to 0.3%.
But the WHO source provides a critical operational detail about that percentage. This prevalence is concentrated primarily among migrants arriving from endemic regions.
And that demographic reality totally shifts the strategic requirement for the country.
It does. A domestic universal healthcare system that functions perfectly for the native-born population has to adapt. It has to capture individuals entering from outside that system.
Because the historical playbook for domestic eradication
hmm
has to evolve when a virus is continually being introduced by populations arriving from areas with limited healthcare access.
The structural challenge becomes one of inclusive public health outreach. To cross the threshold for hepatitis B elimination, the national health infrastructure has to ensure that newly arrived populations are brought into that same 95% screening met.
Which isn't easy. You're dealing with language barriers or people who might fear engaging with government systems due to their immigration status.
Right. But the WHO notes that Denmark is currently on track towards this final validation.
Which indicates their system is actively adapting to absorb and treat these vulnerable migrant populations effectively.
And that brings up another really interesting point from the release. Denmark is the first in the European Union to hit this milestone.
The headline achievement.
Right. But the WHO release places them within a much wider global context. They are joining 22 other countries and territories globally that have already been validated for the elimination of mother-to-child transmission of HIV, syphilis, or hepatitis B.
Or certified on the path to elimination.
Exactly. And the composition of that global roll call is probably the most analytical takeaway from the entire document.
It really is. I mean, listen to some of the countries on this list. You have Cuba, Thailand, the Maldives, Belarus, Jamaica, Oman, Botswana, Malaysia, Armenia.
It's incredibly diverse. You are looking at nations with vastly different gross domestic products, differing political structures, and widely varied historical disease burdens.
It completely shatters the assumption that massive first world capital is a prerequisite for protecting infants from these diseases.
Right. A country like Botswana, which has historically managed one of the most severe HIV epidemics in the world.
Or Cuba, operating under severe resource constraints.
They achieved these benchmarks before the wealthiest nations in Western Europe.
Which reveals a profound truth about public health prioritization.
It does. Wealthy nations often default to highly localized, expensive reactive treatments, whereas resource-limited countries must prioritize universal preventative maternal care.
They have to do it to avoid the long-term systemic cost of a congenital infection. They simply can't afford not to.
And the presence of countries like Thailand and Jamaica on this list proves that the core pillars are scalable.
Political commitment, integration of testing into routine care, and rigorous data tracking.
Those methodologies scale. Denmark's milestone validates their specific domestic model, sure, but the global list proves the underlying public health mathematics can be executed in almost any environment.
If the political will dictates the resource allocation.
Exactly.
So to synthesize the journey we've taken today, based on this WHO release, we moved from the granular data of a single European nation to the architecture of global health policy.
We looked at the strict mathematical thresholds separating elimination from eradication, that 95% capture rate, and those sustained multi-year outcomes.
We dissected how Denmark's universal rights-based infrastructure removes the financial and social friction that usually derails national health initiatives.
And we looked at the clinical realities of the current epidemiological landscape. HIV transmission to infants sits at absolute zero, despite thousands living with the virus.
And the maternal screening net has effectively isolated syphilis to the male population.
Finally, we contextualized this EU milestone within that diverse coalition of 22 other nations, proving that political prioritization can outmaneuver economic limitations.
The mechanics of this success really offer a critical lens for evaluating other systemic health failures. Denmark, alongside nations like Oman and Belarus, drove infant infection rates into the ground simply by weaving the diagnostics into the mundane, everyday reality of prenatal checkups.
It wasn't magic, it was logistics.
It really was. And here's something to chew on as we wrap up, something for you to think about.
Okay.
Denmark proved that weaving these tests into routine default care is what eliminates the disease.
Right.
So as countries like Denmark perfect their prenatal screening to eliminate these diseases natively, how must our global health systems evolve to support migrant populations coming from regions where these diseases are still endemic?
That's the real frontier. Does true elimination ultimately require a borderless approach to healthcare?
If a universal default safety net can eradicate mother-to-child transmission of HIV and syphilis, what other historical public health crises are we currently treating as inevitable simply because we haven't made preventative care a default, invisible part of our daily systems?
It's a powerful question.
Thank you for joining us on this deep dive. Stay curious, Keep analyzing the structures around you, and we will catch you on the next deep dive.